The next topic is going to be the non-surgical treatment options that are available for treating arthritis. Dr. Rogers is an expert in orthobiologics. In addition to talking to some of the more traditional stuff, he is going to talk to you about where the current state of the technology is with the so-called stem cells and other orthobiologics. And I'll turn it over to Dr. Rogers.
Thank you, Dr. Sidha. So I'm a physical medicine physician in San Diego, California. I treat patients with osteoarthritis every day. Our goal for the patient with end-stage disease is to help them avoid getting to that point if possible. It's an indication for total joint replacement would be failure to respond to non-surgical care. So we want to provide excellent non-surgical care. So osteoarthritis is a common condition. It affects most of us, 54 million Americans worldwide, 300 million Americans. We are seeing approximately 1.5 million patients undergoing total joint arthroplasty every year in the United States. And if you do the math, that tells you that the vast majority of patients are being managed without joint replacement surgery. Patients may not be candidates for surgery for a variety of reasons. One may be that they are too young, and there's concern that the prosthesis may not last more than 2 or 3 decades. The arthritis may not yet be at that end stage level, that severe level. They may be at risk for undergoing surgery. They may have cardiac or pulmonary disease that would put them at risk for undergoing a surgery. Or the patient may just simply prefer to avoid surgery. So what I'd like to do is just share with you the non-surgical options that have support in the published scientific literature. Here we're in San Diego, so we have these beautiful beaches and we have a lot of active people. There's actually very good evidence that remaining active, whether it's walking or bicycling or swimming, is not only helpful for alleviating pain and improving patients' overall health, of course, but also actually has been associated with improvement in cartilage health in the joint. We used to think that runners were at higher risk for developing arthritis. The opposite is actually true. Strengthening for those patients who cannot walk or run, but strengthening the muscles around the leg has also been shown to be effective. Weight loss for 2 reasons. First of all, the stress on the joint obviously can produce pain, but the extra fat that we carry around is inflammatory by nature. And osteoarthritis is a chronic inflammatory condition where you have low-grade ongoing inflammation for many decades. And there's evidence that losing weight will reduce inflammation in the body and in the joint. We all know that high-sugar diets promote inflammation in the body, so there's evidence that low-sugar diets may be helpful for alleviating pain. And then there's a whole host of pills and creams and lotions that people try. In the published literature, there's very limited support for many of these. Curcumin, which is also turmeric, has some good evidence. The dose has not been specified. Omega-3 fatty acids, such as fish oil or algae oil, have been shown to be helpful for decreasing inflammation. Vitamin D has been shown to be very important for bone health and cartilage health. And most of us are deficient in vitamin D, and this can be measured very quickly and easily with a blood test. Glucosamine and chondroitin, there's mixed evidence in the literature. Glucosamine and chondroitin are molecules that are found naturally to occur in cartilage. And although they don't grow cartilage in the joint, they do seem to help with inflammation and with pain. And then for some patients who may have instability or slight alignment problems with the joint, knee braces can be helpful. When these conservative treatments are not helpful, then you may come to one of us for some kind of injection into the joint, of which there are many kinds. And I'd like to first state that it's important that your physician have and is able to use an ultrasound machine. Just like you would use ultrasound to look at a baby, ultrasound can be used to look at the knee. And so you see the probe there on the patient's knee. And this is important because the accuracy of the knee injection has improved. In the hands of very skilled surgeons, the miss rate can be as high as 25%. If you don't use ultrasound, ultrasound drastically improves the accuracy of the injection. It also improves the comfort of the injection. It can improve the efficacy. It makes sense that if you're actually injecting your substance into the joint, that you're going to improve efficacy. And by improving efficacy, there's also been shown to be cost effectiveness and reduction in cost. This is what the ultrasound looks like. So if you can imagine your left knee, and the ultrasound is looking into your left knee, and on the top there is the skin, and then the deeper layer would be the bone. And you can see the black fluid in the middle there. That's our target. That's where we want to put the needle, because it won't hurt if you numb the skin and then put the needle in that space. So if you go ahead and hit play, you'll see the needle moving from the left in the left knee. And you can see it moving into that space there. And the resolution of the ultrasound is so good, you can actually see the hollow part of the needle. And so this allows us to perform these procedures with comfort and not worry about the needle bumping into a soft tissue that might be painful. So steroids have been around for more than 70 years. Steroids have an anti-inflammatory effect. We told you that osteoarthritis is an inflammatory condition. And even though you're not growing back the cartilage, if you can decrease the inflammation, you can get temporary pain relief. Unfortunately, pain relief is typically less than 4 months, has been associated with potential damage or decrease in cartilage thickness. And it's advisable to avoid repeat injections any closer than 3 months apart. Viscosupplementation with hyaluronic acid gel, of which there are many different kinds, has been shown to be associated with pain relief up to 24 weeks. And it's thought to do this by cushioning the joint or lubricating the joint. Unfortunately, this has only been approved in the US for knee osteoarthritis. It's not approved for hip osteoarthritis. And it's starting to fall out of favor as certain third-party payers are no longer reimbursing for this treatment. So this brings us to other injectables, which we call orthobiologics. Orthobiologics refers to those substances that contain cells or contain products that are produced by cells, such as growth factors. And I'm showing you these different ingredients to make the point that there are many different combinations of cells and different biologics that are being studied in the medical literature. The most common would be platelet-rich plasma, or PRP, and cell sources such as bone marrow or adipose tissue. So PRP is where we use your own blood, which contains platelets, and it's been shown to have good safety, and we now have level 1 evidence that it is more effective than steroids and more effective than hyaluronic acid gel. It's more effective for mild to moderate disease, not as effective for the more severe bone-on-bone disease. Bone marrow aspirate contains stem cells, but also platelets and other orthobiologics and molecules that have been shown to be helpful for pain associated with osteoarthritis, in that these molecules can decrease inflammation, they can promote cartilage health. There are a few studies that show that they actually do regenerate cartilage, and pain relief has been documented up to 3 years and is more effective in the more advanced knee osteoarthritis. There's actually quite a body of literature. Each circle there represents a clinical study that may contain anywhere from 10 to 100 patients. And so you can see there's just over the time, there's been a growing number of clinical studies that have looked at stem cells derived from bone marrow in the use of osteoarthritis. Fat tissue or adipose tissue is also a very rich source of cells that have been shown to be helpful for knee osteoarthritis. They have a good safety data. They've been shown to decrease inflammation. There are several studies now that show on MRI or on biopsy of the cartilage in the knee that these cells can promote cartilage growth in the joint. I'm actually preparing to publish a paper with 48-month follow-up in patients showing very good efficacy and very good safety when using this technique. And you can see the fat tissue there in that image is being washed in a device, and then it's injected into the patient's knee under ultrasound guidance. And again, these are studies. Now, each circle represents a study where cells from fat were used to treat patients with osteoarthritis. And this year alone, we have now 6 studies, of which 2 are prospective randomized clinical trials. So the data has improved. The quality of the research is improving each year. And there's different ways to prepare cells from fat. We can simply perform a lipoaspiration or liposuction procedure in the office and remove some fat and rinse and wash it in the office and inject it into the patient's knee at the same time. Or you can send that fat on ice by FedEx to a facility where the cells are separated from the fat and isolated and grown. but this can only be done under FDA approved clinical trials. And I'm medical director for a company that's actually conducting a study right now to look at these cells in the osteoarthritis. Finally, I'd just like to bring attention to the fact that there are now more than 1,000 clinics in the United States that promote products that are not FDA approved and have not been well studied. So unlike bone marrow or fat-derived cells, these products, which are derived from typically umbilical cord blood or placenta or amniotic fluid, have been promoted as a stem cell treatment when they are not. Studies that have looked at these products show that they do not contain live stem cells. They are not FDA approved. In fact, the FDA has issued warning letters to these companies asking them to cease and desist. There have been cases of infection in patients who have received these products, and the claims that are often made on these websites are not supported by the current scientific evidence. So in general, we want to make sure that your physician is appropriately trained, that they've obtained training in regenerative medicine, since we don't typically get this in med school or residency, that they understand how to use ultrasound when they perform their procedures, that they're using products that are compliant with current FDA guidelines, and they're making decisions that are based on the published scientific literature. Thank you.
So this is a poll question for those of you in the audience. So which biological stem cell treatments did you look into? So if you could, we'll give you about 20 to 30 seconds to answer which of those you looked into. You can answer more than one if you looked into more than one. Chris, so one of the things with biological treatments is this, I think, differentiation between pain relief versus cartilage regrowth. And yes. I'm quick to tell people that you may or may not experience pain relief, but there's very limited data on actual regrowth of cartilage. Would you agree with that statement, or at least correct me where I'm incorrect there?
So it's important to understand that each of these biologics has different potential to influence the cartilage tissue. So for example, we typically do not see cartilage growth with PRP in many of the bone marrow studies as well. The second issue is how bad is the injury? But you're right, there's a difference between alleviating pain and growing cartilage. So for example, if we inject cortisone into your knee, we decrease inflammation temporarily, which alleviates pain. These biologics also modify the immune system and decrease inflammation, but for periods of time that are much longer than steroids would be. So PRP can last up to a year. These cells from bone marrow and fat, as I showed you, can last 3 to 4 years. The best evidence we have for cartilage growth is with the use of stem cells derived from fat, where physicians actually took a biopsy from the patient's knee. So you can imagine now you've had stem cells injected into your knee from your own fat, and now 2 or 3 years later, we take a biopsy of the cartilage to measure whether or not that cartilage has grown. And there is some good evidence, but I would still characterize it as these are early findings.
Thank you very much. So the results of our poll, 65% of patients didn't look into any stem cell type of treatment, 21% looked into PRP, 9% bone marrow, 4% umbilical cord, and 1% fat adipose. And since the best data right now is with PRP, bone marrow, and fat, we probably need to get the word out about fat a little bit more.